The topic is about endometriosis-associated infertility. My benchmark in this journal club is endometriosis-associated infertility from pathophysiology to tailored treatment review article by Bonavina and ISHRI guidelines about endometriosis 2022. First, endometriosis is a disease characterized by the presence of endometrium-like epithelium and the stroma outside endometrium and the myometrium, and usually associated with inflammatory process. On the other hand, adenomyosis is the presence of endometriotic spots inside the myometrium itself. In order to say endometriosis-associated infertility, you have 2 points. Number one, the diagnosis of endometriosis, this woman complaining of infertility. So there must be infertility and endometriosis. Infertility is a failure to achieve conception or pregnancy after 1 year or after 1 year of unprotected intercourse or 6 months of unprotected intercourse if a woman more than 35, plus the presence of sure diagnosis of endometriosis. If you go back to the basic science, the mechanisms of infertility in endometriosis may be mechanical due to pelvic adhesion, distortion of fallopian tube or tube-ovarian relationship, affection of folliculogenesis due to chronic inflammatory process in the peritoneal cavity, affection of sperm function and motility or spermoocyte interaction. Dyspareunia also has a factor or impact on the infertility due to endometriosis due to severe pain if it is associated with deep infiltrating endometriosis. Also, ovarian microenvironment, especially if there is endometrioma increase the reactive oxygen species in the ovary, which affect folliculogenesis and the oocyte quality. If the case, go for surgery and have endometrioma excision, so there is affection also of ovarian reserve. Endometrial receptivity may be affected due to endometriosis or adenomyosis. Endometriosis has also a systemic effect in the form of chronic inflammatory process or affection of metabolism. All of these mechanisms affect infertility. So, how to assess a case of infertility associated with endometriosis? Number one, you should exclude male factor or assess carefully male factor by doing semen analysis in order to exclude cases with severe oligoethylene teratospermia or azoospermia, which is a candidate for IVF or ICSI from the first. Then you go for 2D ultrasound in order to assess the uterus to exclude the presence of adenomyosis. We have a criteria of ultrasound for adenomyosis by the thickened wall or the whole MUSA criteria for adenomyosis. Then you assess the adenexa, assess the ovary but for the presence of endometrioma, which is a ground glass appearance, thickened wall, decreased vascularity in the wall of the cyst, and then assess the fallopian tube by ultrasound to exclude the presence of hydrosalpinx. Don't forget to do sliding test while you are doing 2D ultrasound. If you watch this video, there is positive sliding test, the Powell slide, a Douglas pouch slide over the uterus, so you can exclude the presence of obliterated Douglas pouch or Douglas pouch adhesion. On the other hand, if you look to this RVF uterus with rectal adhesions and frozen Douglas pouch or obliterated Douglas pouch, this I think it has a big problem with infertility due to severe pelvic adhesions. Also, don't forget to measure antral follicular count and do AMH, serum AMH, in order to assess ovarian reserve, to categorize your patient whether she is good responder or average or low responder. It will affect majorly your decision. Lastly, you assess the patency of fallopian tube by doing hysteroangiogram in order to categorize the patient whether she has blocked fallopian tube, so she is a candidate for IVF, or she has a patent fallopian tube, so you can proceed for further management. Many classification was put for a classification for endometriosis. One of them revised American Fertility Society classification. But this classification isn't helpful for management of infertile case. It only categorizes patients according to surgical difficulty or surgical severity. but it hasn't any probability for pregnancy or predictivity for pregnancy. On the other hand, the endometriosis-associated infertility is a classification or staging for endometriosis, which has a good predictivity for fertility. Endometriosis fertility index is a combination of historical factors, which is the age of the patient, years of infertility, and history of prior pregnancy or not. Every point is taken a point or a score. Then you have the sum of this score, which is a historical factor. Surgical factor is composed from least function score. After you complete your surgery, you do the least function score, which you assess fallopian tube, fimbria, and ovary. If it is normal or there is mild dysfunction, moderate dysfunction, severe dysfunction, or absent or non-functioning, you have a score for right and left, fallopian tube, fimbria, and ovary. And then you have the sum, which is least functional score. If least functional score is from 7 to 8, you have 3 points. From 5 to 6, you have 2 points. And less than 3, you have 0 points. Then you go for American Fertility Society endometriosis score and the total American Fertility Society score. And then you have the sum of historical and surgical factors, and then you have endometriosis fertility index score. You put it in this chart, and then you have the probability of pregnancy in the next 3 years after surgery. Many reviewers and authors take a score of 6 as a cut level. So cases with endometriosis fertility index more than 6 have a good probability of pregnancy in the next years. On the other hand, equal to 5 or less than 5 has a lower probability for pregnancy. Also, sliding test has a good probability and predictivity for pregnancy. If you have a negative sliding test with endometrioma plus endometriosis fertility index historical factors, you can diagnose a case with a score less than 6 and decreased probability for natural pregnancy. So if you go to management, according to the ISHRI guidelines, they said to consider number 1, pain, and then age of the patient, duration of infertility, ovarian reserve, estimated endometriosis fertility index, history of previous surgeries for this case, and other factors such as male factor or tubal factor before you put your plan for management of this case. Also, they said avoid multiple surgeries for endometriosis. There are a lot of medical treatment put for endometriosis in order to treat pain, which is GnRH agonist, antagonist, progesterone, combined pills, non-steroidal, and aromatase inhibitors outside ovulation induction, but they have no role for fertility treatment. So avoid to write medical treatment for treatment of fertility for endometriosis. Also, ISHRI guidelines said that in infertile women with endometriosis, clinicians shouldn't prescribe ovarian suppression treatment to improve fertility. Also, don't prescribe pentoxifillin or other anti-inflammatory drugs or letrozole outside the context of ovulation induction to improve natural pregnancy rates. This is a case of 24-year-old woman complaining of primary infertility for 1 year, normal semen parameters for her husband, regular menses, and AMH 3.5. She has a small chocolate cyst on the left ovary, normal right ovary, and positive sliding tests. I want to listen to your opinion by the end of the lecture about the management of this case. Do you think we can have expectant management for a case of endometriosis complaining of infertility? I think if she is a good prognosis patient, young age, short period of infertility, and good endometriosis fertility index, I think you can give her expectant management for a while. Regarding reproductive surgery, guideline development group recommends that the decision to perform surgery should be guided by the presence or absence of pain symptom, patient age, preferences, history of previous surgery, presence of other infertility factors such as male factor or tubal factor, ovarian reserve, and estimated endometriosis fertility index. This study showed that the cumulative probability of pregnancy at 3 years after surgery was 47%, whatever the ASRM stage. On the contrary, it was about 33 in case of moderate endometriosis and 0% for severe endometriosis after expectant management. On the other hand, is low and moderate quality evidence that surgery may affect the clinical pregnancy rate or miscarriage rate, even live birth rate after surgery. This was a systematic review and meta-analysis. If we start by ASRM stage 1 and 2 or minimal to mild endometriosis, ISHRI guidelines said that operative laparoscopy could be offered as a treatment option for endometriosis-associated infertility in minimal endometriosis to improve the pregnancy rate of ongoing pregnancy. Also, this was confirmed by this meta-analysis, which also confirmed that operative laparoscopy increases natural viable intrauterine pregnancy rate after operative laparoscopy in cases of minimal to mild endometriosis. You need to treat 12 patients with minimal to mild endometriosis in order to achieve 1 pregnancy. On the other hand, you need to treat 40 patients complaining of unexplained infertility by operative laparoscopy in order to achieve only 1 pregnancy. Regarding asymptomatic endometrioma, clinicians may consider operative laparoscopy for treatment of endometrioma-associated infertility, as it may increase the chance of natural pregnancy, although no data from comparative study exists. This study showed that there is evidence suggests that surgical and expectant management are equal. There is no upper hand for surgery or expectant management. But take care, surgery for ovarian endometrioma affect ovarian reserve. So you should know that if the effect of bipolar coagulation is more than suture and sealants. Avoid blind coagulation. Another technique was put in order to decrease the burden for ovarian reserve, which is combined technique of Jacqueline, but there is no difference in regarding ovarian reserve. Also, a 3-step technique was put. I want to know your opinion about this technique, which is drainage and then wait 3 months by GnRH agonist and then go for laser fulguration. They said they give better results regarding ovarian reserve. And I want to know your opinion about this 3-step technique. If you have a case of recurrent endometriosis, take care. You have a lower probability of pregnancy if you go for surgery and lower oocyte and embryo yield. Deep infiltrating endometriosis, according to ISHRI guidelines, don't operate except you have endometriosis-associated pain or visceral obstruction. Otherwise, don't do any surgery for this case. I want to know which patient need ART after surgery. I think any case after surgery who have a lower endometriosis fertility index, she is a target or a candidate for ART after surgery. So in conclusion, for reductive surgery, operative laparoscopy could be offered as a treatment option for endometriosis-associated infertility for minimal and mild cases. You can consider operative laparoscopy for endometrioma. There is no compelling evidence exists that operative laparoscopy for deep infiltrating endometriosis improve fertility. If you go to ART, ISHRI guidelines said that an infertile woman with minimal to mild endometriosis, clinician may perform IUI with ovarian stimulation instead of expectant management or IUI alone, as it increases pregnancy rate. Also, they said that you can do IUI for cases moderate and severe endometriosis if they have patent tube. Really, I don't think that IUI may be helpful for cases with moderate or severe endometriosis because IUI in general have a lower probability of pregnancy, and I don't think that IUI may be of benefit for cases of moderate and severe endometriosis. Also, I want to know your opinion. If you go to IVF, can you perform it for infertility associated with endometriosis, especially if tubal function is compromised or there is severe male factor or azoospermia or low endometriosis fertility index? Regarding protocol for IVF, there is no upper hand for any protocol. So GnRH agonist equal to GnRH antagonist protocol regarding live birth rate and complications. Also, you should reassure the case about safety of ART for endometriosis patients. There is no increase in the recurrence rate due to ovarian stimulation drugs. If you go for OPU, you should give antibiotic prophylaxis at the time of oocyte retrieval in order to avoid ovarian abscess formation from your puncture. Ultra-long protocol or extended suppression. Till 2019, Cochrane reviews by Dr. Hassan Salam said that ultra-long protocol or GnRH agonist for 3 cycles before ovarian stimulation increased the probability of pregnancy by fourfolds. Till 2019, Dr. Hassan Salam published another Cochrane review or updated his Cochrane review, and he said there is no rule for ultra-long protocol or extended suppression before ovarian stimulation. So you shouldn't give 3 cycles of GnRH analog before starting your EXI cycle. Also, there is insufficient evidence to recommend the prolonged administration of COX or progesterone as a pre-treatment before ART in order to increase live birth rate. I think prolonged suppression by progesterone or COX lead to endometrial atrophy and very thin endometrium. So when you prepare the patient for embryo transfer, I think you face another problem, which is thin endometrium persistent, thin endometrium resisting to medications. This is a summary of current evidence regarding IVF. So GnRH pre-treatment or ultra-long protocol, there is no benefit. GnRH agonist stimulated cycle, no benefit over antagonist. GnRH antagonist gives the same results as agonist with improved safety profiles and patient-friendly. Progesterone primed ovarian stimulation cycle is a good option when no fresh embryos transfer is planned. Lastly, pre-surgical oocyte vitrification is a good idea for cases in order to improve reproductive outcome, especially in young women with endometriosis or recurrent endometriosis. So what about surgery before ART? Clinicians aren't recommended to do routine operative laparoscopy for minimal to mild endometriosis before ART. Also, they aren't recommended to perform surgery for endometrioma to improve live birth rate before ART because it has a negative impact on ovarian reserve. Surgery for endometrioma before ART can be considered to improve endometriosis-associated pain only or to improve your accessibility to the follicles. The decision to offer excision of deep pelvic endometriosis lesion before ART should be guided mainly by the pain symptoms and patient preferences because it doesn't affect the probability of pregnancy after ART. Also, if you have a case with hydrosalpinx, you should go for surgery for hydrosalpinx before going for IVF. If you have a chocolate cyst when you are not sure for the diagnosis, or you have a typical chocolate cyst or rapidly growing chocolate cyst, I think you should go for surgery in order to confirm diagnosis. So after doing surgery for endometriosis before ART, when to start your stimulation? This study showed that the optimal time to perform IVF appear between 7 and 25 months. But I think it's a very long period which give time for recurrence to occur. I think 3 cycles after endometriosis surgery is a good time to give time for inflammation to resolve and for the ovary to restitute itself and give a good oocyte yield. Don't forget there is a risk of contamination during OPU, so avoid endometrioma puncture during OPU. And if accidentally puncture, give a good antibiotic coverage. Wash oocyte carefully if contaminated follicular fluid with endometrioma. Lastly, fertility preservation. In case of extensive ovarian endometriosis, clinicians should discuss the pros and cons of fertility preservation with women with endometriosis. The true benefit of fertility preservation of women with endometriosis remain unknown. The indication of fertility preservation in endometriosis is cases of recurrent endometriosis, bilateral endometriomas, endometriosis surgery in a young age, and cases with poor ovarian reserve. This is a proposed flow chart for managing a case with infertility associated with endometriosis. So first, do your infertility workup. If there is other indication for IVF or ICSI, such as severe malfactor or tubal block, so go ahead for IVF or ICSI. Then assess ovarian reserve. If you have a case of old age or poor ovarian reserve, also go ahead for IVF and don't waste your time. Then, if you have a good prognosis patient, there is suspicious of minimal to mild endometriosis, you can go for surgical management and controlled ovarian stimulation for 3 cycles or 6 cycles with or without intrauterine insemination. If there is suspicion of moderate or severe endometriosis, so it's a patient-specific decision-making, you can go either for IVF or ICSI directly, or go for surgical treatment and then ovarian stimulation with IUI, and if failed, go direct for IVF and ICSI. This is the first case I showed to you, which is good prognosis patient, which is 24-year, 1-year infertility, normal semen parameter, and regular menses, and with good ovarian reserve, with small endometrioma. I want to know your decision. Also, this case is scheduled for ICSI with a good ovarian reserve, and she had 2 endometrioma. One is 7 centimeter and the other is 4 centimeter. And also, this case is scheduled for ICSI also with small endometriomas with no hydrosalpinx. Before the end of this lecture, I want to invite you to follow our Facebook page of Endometriosis Every Interest Group in order to be updated with our next meetings and our next journal club and activity, and share your experiences. Thank you.